Hello and welcome to the LSVT LOUD webinar entitled Evidence-Based Speech Treatment for Parkinson Disease. And this is a special webinar that we've developed for students in speech-language pathology. So we're really thrilled to have all of you with us here tonight. Our presenters for this evening include Dr. Lorraine Ramig. She is a research professor at the University of Colorado in Boulder. In addition, she is one of our founders of LSVT Global, and also a senior scientist at the National Center for Voice and Speech. And if you've done any work or any research on LSVT LOUD, you know that she is the more than the founder of the company, she is the impetus for the treatment, developed it, and has been the primary investigator on all of the research. And so it's exciting to be able to have her here with us tonight to be part of this presentation. Our other presenter is myself. I'm Cynthia Fox. I'm a research associate at the National Center for Voice and Speech, as well as one of the co-founders of LSVT Global. And I have worked with Dr. Ramig for, it's hard to believe, but over 20 years now in information related to LSVT LOUD, research, clinical implementation, and a whole range of developments that we've had. So our plan for this evening, and we welcome you if it's evening for you, or perhaps some of you are joining us from international locations and it's morning or the middle of the night, is that I'm going to do a few brief logistics. We'll then present the webinar. At the end of the hour, we will answer questions, and if we have a lot of questions, we'll stay on for a few extra minutes, maybe about 10 minutes. And then at the end, when you close out of the webinar, there'll be a survey that launches that has just a few questions. It will take you less than 5 minutes to complete. So we really encourage you to please complete that survey, give us feedback. We pay attention to that, and we use that as we plan future webinars. So logistic-wise, one logistic is about questions. And so you will have the opportunity to ask questions. There's multiple ways. At any time during the webinar, you can type in a question, and you should see that question pane on your computer screen. You can also raise your hand, and there's a little hand that you click, and at the end when it's time for questions, I can unmute you and you can ask your question that way. Or at any time, you can email questions to webinars@lsvtglobal.com. In particular, if there's a question you come up with that we don't have time to answer or you think of after the fact, we're happy to do those answers. And I'll review that process at the end of the hour. In terms of CEUs, this is offered for 0.1 CEU for the hour. You need to be here for the full hour to earn that CEUs. These are not ASHA registered CEUs, so we won't collect your ASHA number and submit them for you, but you will receive a certificate after completion. I would keep that. Also keep these handouts, because a lot of the information in the handout is what's important if you're using self-reported CEUs. And there's a link on here, and this link will be in your handout as well. If you've not used self-reported CEUs, you can do that. Also, this is a student webinar, but if you have a NISHLA number, my understanding is that you can start to collect information on CEUs as well. And we're happy to answer additional questions on that offline if you need more information. There's also a handout associated with this. You may have had the opportunity to download and print it ahead of time. If not, know that it's there. If you have difficulty accessing it, let us know and we can email it to you so that you have record of your attendance as well as notes about the webinar. This information, your biosphere instructors, Dr. Ramig and myself, I won't read through this, but again, that can be useful if you are saving this for future CEUs. And we absolutely provide our disclosures in that all LSVT Global faculty who present webinars have financial and non-financial relationships with LSVT Global. Non-financial relationship includes a preference for LSVT loud as a treatment technique and some of the equipment that we'll discuss tonight when we talk about technology. Dr. Ramig and myself also receive a lecture honorarium and travel reimbursement, and we have ownership interest in the company. We are in full compliance with our university's research committees in terms of conflict of interest. We also like to recognize that we're very grateful for patients who have provided consent for us to show some of our pre-post videos that you'll see as part of this webinar. And these videos represent work from 25 plus years of research. So although some of the footage is from our older studies, it may not be shot, well, it was not shot in high definition. It's been chosen for demonstrating key important learning elements related to LSVT loud. And so please take it for the point that it's making and not always necessarily the highest quality of video that we collected during our 25 years of research. So our objectives for this 1 hour presentation are as follows. We want to briefly explain advances in neuroscience that have had a positive impact on the field of rehabilitation for individuals with Parkinson's disease. Then we'll discuss the development and data on LSVT loud, explain some key principles of the treatment, highlight some innovative technology that can really enhance accessibility for treatment protocols such as LSVT loud that are consistent with principles that drive activity-dependent neuroplasticity. And at the end, given this webinar really is focused on students, we want to summarize the ability of students to be able to learn and use LSVT in their clinical practicum while they're graduate students or in their clinical fellowship year. So with that brief introduction, we're now going to move on to our first interactive moment of the evening, and we have several polling questions that we're going to ask throughout the evening. And the first one that should now appear on our screen is simply asking, who are you? So we're excited to know who it is that we're speaking with tonight. So we'll let the poll run for just a few moments. And if you can answer and let us know who you are. And let's see. All right. And so our results should be coming up now. And it looks like we have mostly graduate students. 83% of you are graduate students. That's fantastic. 4% undergraduate, good for you. Joining in with us, we have some university faculty and clinical supervisors, some professional speech-language pathologists, and a few others that didn't quite fit into that category. So that's great. We're excited to have you with us, all of you. We have another poll question here. Just give me a moment to be able to pull it up and share with you, and then we'll move on to our content. So our next poll question is this. How did you learn about LSVT loud? So we're curious if you learned from a lecture in school, observation and treatment. Were you doing research, our website, word of mouth? So we'll give you a few moments there to let us know. Okay. A few more seconds. We've got a few more people still voting. All right, so let's take a look at our responses now, and it looks like the majority of you either learned from a lecture in school or from word of mouth. So that's great. Again, welcome. We're excited to have you here with us, and it really helps us to know who's out there listening as we go throughout this presentation tonight. And we'll pull you back in to be interactive again 2 more times throughout this 1 hour session. So let's see if I can get my slides back up on screen. There we go. And we will continue on. So in terms of our first objective for the evening, to talk about advances in neuroscience and the impact they've had on our field, Well, the 1990s were really deemed the decade of the brain. And there was a focus in the field of neuroscience to better understand neural function. And out of that really concentrated effort came the recognition of the adaptive capacity of the central nervous system. And this term, activity-dependent neuroplasticity. So really recognizing changes in the brain that can happen in response to activity. And that activity is certainly what we do in terms of speech language therapy. So we always like to acknowledge that it's really a stunning time for us today to be in the field of neural rehabilitation. And some of that basic science evidence from that concentration in the 1990s has elevated the value of exercise. And when we speak of exercise, voice, speech exercises that we do as part of rehabilitation, in terms of the care of people with Parkinson disease. So whereas classically it was predominantly treated neuropharmacologically, neurosurgically, today the value of rehabilitation and exercise upon diagnosis is very much a part of the care and management of people with Parkinson disease. That literature also identified key principles of exercise that drive activity-dependent neuroplasticity. And we'll talk more about these in just a moment. And it demonstrated that in animal models of exercise and Parkinson disease, that exercise can improve brain functioning and may actually slow disease progression. So this idea that exercise is medicine, and just as important as the pills individuals take to help control and manage their symptoms from a neuropharmacological perspective, what we do in rehabilitation, and in particular speech rehabilitation for what we'll talk about tonight, is very important. So some of those principles that drive activity-dependent neuroplasticity are listed here, and this is not an exhaustive list. You have a number of references there if you want to learn more, or many of you probably are learning this right now in your graduate programs, but I just want to highlight a few of them. One is intensity matters, and this doesn't matter if you're treating Parkinson disease, post-stroke, cerebral palsy, any neural deficit affecting communication. Intensive practice is important to drive change. Complexity of practice is important. So the more complex or environmentally enriched the environment is, the greater plasticity will occur. And we'll mention briefly how we achieve that in LSVT LOUD. Repetition matters. So the more repetitions, the greater plasticity. And what's important to recognize is we need repetitions beyond just learning the skill in order to really achieve underlying neurological changes. Salience matters. So practicing things that are rewarding, meaningful, emotionally important to people, activate basal ganglia circuitry, and drive greater plasticity. And this is an important point because even though LSVT LOUD is a standardized protocol, you'll see when we talk about the protocol later in the presentation, we can 100% tailor it to each individual person. Timing matters, and so these can be things in terms of how early we start treatment. It may be different for different disorders, but for people with Parkinson disease, we believe that early is probably better. And then specificity of training matters. So we want to train the deficit that we want to improve. And in Parkinson disease, it's this idea of hypokinesia. So hypokinesia in the speech mechanism results in soft, monotone, in some cases mumbled type of speech. So our LSVT programs and LSVT LOUD that we'll be speaking of tonight adhere to these principles of plasticity. So today we see that rehabilitation, speech therapy, as well as physical and occupational therapy really are becoming a routine part of management in people with Parkinson disease, both to provide symptomatic relief as well as improve function. And you'll see that the circles overlap. So it's not one or the other, but the best combination of all. But what's unique about behavioral therapy and what we do as speech language pathologists is that it can really empower patients because it's something a person learns how to do, they can control, and that gives them a sense of empowerment in terms of managing their own disease. So our work over the past years, and it's been 25 years of NIH funding, again, led by Dr. Lorraine Ramig, has brought us both in terms of research and clinical experience where we are here today. And we're always learning, changing, and growing, and that's what makes this so exciting. And LSVT LOUD is the speech therapy that we've developed. It's delivered by LSVT LOUD certified speech language pathologist. We won't talk about this today, but you may have heard of LSVT BIG, and that's a complementary physical or occupational therapy that's based upon the same principles of the speech therapy. So what we'll do now is take a look at our first video. And this is a quintessential pre-post video of a woman before and after LSVT LOUD. She was 2.5 years post-diagnosis. She's on her medication pre, on her medication post. No changes during the 1 month of intensive treatment. Now, here's one thing to consider when you watch the videos. With the webinar, there's oftentimes a lag in the video, so the actual visual may be a bit choppy, but the audio should come across clear. And if you wanted to watch this online without it potentially being choppy, on our website under the News and Views tab, this video is listed. So let's take a look now at Shirley.
Have you noticed any changes in your speech or your voice that you would associate with Parkinson's?
Yes, I don't speak loud enough a lot of times.
Anything else?
Hoarse.
Anything else?
I stutter, which I never did before.
Do this for me if you would. Take a deep breath and say ah for as long as you can. Good for you. Okay. Would you say Parkinson's disease has caused you to talk less?
Yes.
Because?
Because I stutter and then I can't be heard. If there's noise in the house, like when the kids come over, nobody pays attention to it because they can't hear me. Until I get mad. Yell.
Take a deep breath and say ah for as long as you can. Have you noticed changes in your speech or your voice as a result of the speech therapy?
Oh, yes.
What have you noticed?
I talk louder. I think louder. I'm going to sing with the Sons of Pioneers one of these days with my voice.
Good for you. That's excellent. What practicing do you do at home?
My ahs, my highs, and my lows. And I read out the mail out loud.
Excellent. Do you feel like practicing helps?
Oh, yes.
Okay. Do you feel as though people can understand you all of the time now?
Majority of the time, unless it's my husband, and he'll say, "Well, I can't hear you."
Good for you.
But I think he does that just to be cute.
I think he does too. Has anyone commented that it's easier to understand you now?
Oh, yes. I set some of our friends back when we went to their house and I talked loud. Lou says, "What the hell happened to you?" My daughter said, "Oh, Ma, that's you?"
Isn't that good? Don't you feel wonderful?
Oh, yeah, because now she can't say, "I didn't understand what you said."
Right? No excuses, right?
Yeah,
That's
no
right.
excuses.
All right. So what do you do when you want to be as easy to understand as possible?
Think loud.
Okay, so Shirley is a really excellent example of the power of behavioral speech therapy. And obviously she got louder, but I think you could probably observe other things changed as well, even if the video was a little jerky. And one of the key things you may have noticed is that her attitude, her confidence, and the treatment didn't give her that personality. The impact of LSVT Loud unmask that personality that is Shirley, and she was able to express herself. She was louder, her voice quality was better, her intonation was better, and that's what's exciting about treatment that has a single target that can have an impact across multiple speech subsystems. Okay, so with that introduction, I am now going to turn it over to Dr. Ramig, who will walk you through the research and development of LSVT Loud.
Thank you, Dr. Fox, and welcome. We're absolutely thrilled to have this large group of individuals to hear what we have to say today about speech treatment and Parkinson's. I welcome you warmly, and I feel you are already inspired by Shirley. She never ceases to inspire us with the changes we see following behavioral treatment. So let's begin and talk a bit about speech disorders in Parkinson's and development of LSVT Loud. Next slide. To review, we know that over 89% of the nearly 6 million individuals with Parkinson's disease worldwide suffer from voice and speech disorders. The classic symptoms, well published in the literature, include reduced vocal loudness, hoarseness, monotone voice, and imprecise articulation. Next, we recognize that these voice and speech disorders contribute to lifelong frustration, embarrassment, and social isolation. They are really substantial in terms of their negative impact. This was summarized by one of our patients who said, "If I have no voice, I have no life." We also recognize, next slide, that classic medical treatments alone do not consistently or significantly improve speech in Parkinson's disease. Pharmacological treatment as well as neurosurgical treatment, while they may have quite profound positive impacts on limb motor function, do not consistently or effectively improve speech in Parkinson's disease. When we began our research back in 1987, despite the efforts by many outstanding speech clinicians, there were no effective voice and speech treatments for Parkinson's disease. Next slide. This is Mrs. Lee Silverman. She was a patient with Parkinson's disease, and when I first met her family back in 1987, even though she was in a wheelchair and she had many symptoms associated with her Parkinson's, her family expressed, "If only we could hear and understand her." This was their primary desire, to be able to communicate with their mother and spouse, because it was so challenging as she was moving to end stages of her life. Next slide. So with this motivation, for 20 years, we have worked on inventing a treatment that is effective for patients with Parkinson's disease and scaling up access to this treatment. We've been very, very blessed by NIH for funding for over 20 years, and we have moved through the various phases of treatment research from phase 1 and phase 2, initial invention, phase 3, looking at efficacy studies, how does this treatment work in a research laboratory, and not just does the treatment work, but what are the underlying physiologic changes accompanying successful treatment. And then we move to phase 4 and 5, which is how can we make this treatment that is efficacious in a research laboratory scale up so that patients around the world can have access. And so we followed this pathway over 20 years, and today I'll be showing you some of the research data that we have accumulated. Next slide. it looks like a poll question, and Dr. Fox will lead you into the poll.
Excellent. So before we get into all of our data, we're just curious, how many of you are already LSVT certified? So we'll open that up and take a few moments to get some answers. Okay, and so it looks like 94% of you have not received LSVT LOUD certification and 6% of you have. So that's great to know. So a lot of you may be learning some of this for the very first time. And we're back to our slides, and I'll turn it back to Dr. Ramig.
Perfect. So let's look at some LSVT LOUD outcome data. As we all know today, the concept of evidence-based practice is enormously important in what we're able to provide to our clients. And you have many, many outcome studies documenting evidence associated with LSVT LOUD. And I'd like to walk through with you some of those studies today. Next slide. In the beginning, we conducted 2 randomized clinical trials to test the efficacy of treatments to improve vocal loudness. We recognize that reduced loudness is among the first and most pervasive symptoms in Parkinson's disease. One study stimulated high respiratory effort treatment, and another study stimulated high effort voice treatment in 45 individuals with Parkinson's disease. They were studied pre-post, pre-12 months, and out to 24-month follow-up. A second randomized control trial compared high-effort voice treatment, LSVT, to 2 untreated control groups, one group of Parkinson individuals and a healthy control group. In this study, we looked at 44 individuals from pre-post to 6 months. Our primary outcome variable was sound pressure level, and here we have the effect size summarized. Back when we did this research, LSVT was considered very novel. It was novel for a number of reasons. One, we delivered the treatment intensively, 16 sessions in a month, which was very uncommon for speech treatment. It was delivered in a high-effort mode designed to target the physiology underlying reduced loudness. It had a single treatment target, not multiple treatment targets, which were very common in speech treatment. Take a deep breath, over-articulate, slow down, have intonation, and get louder. We had one single treatment target of increasing loudness, which allowed us to enhance feasibility of generalization. So a patient could actually walk out of the treatment room and remember one thing, increased loudness, which would have a big impact on their overall communication. And we addressed what we've come to learn as a really important element in the world of Parkinson's, which are sensory challenges. In addition, the treatment was delivered consistent with the motor learning literature and the muscle training literature. Next slide. So here we have the first level 1 evidence for a speech treatment in Parkinson's disease. On the vertical ordinate is sound pressure level from the Rainbow Passage, and the horizontal ordinate is months in time. You see pre-treatment on the far left. Patients are exactly at the same level in sound pressure level, and what you see is LSVT LOUD is in orange, and the respiratory treatment is in blue. If you follow across, you see pre, post, 6 months, 12 months, and 24 months follow-up. These data were published in 2001 and reflect, as I said, the first level 1 evidence. And they're considered level 1 evidence because of 2 variables. At 2 years follow-up, patients who received LSVT were statistically significantly louder than they were pre-treatment, and they were statistically significantly louder than an alternative treatment group, the respiratory treatment. Next slide. One of the other elements we examined in these patients pre-post treatment, in addition to this primary outcome variable of sound pressure level, were changes that occurred across the entire vocal tract. And you look at the speech mechanism, and if we look at the right side, you'll see a listing of variables that we measured and articles published. Jennifer Spielman and Joan Borad looked at facial expression, Christopher Dromey, articulation, Shimon Sapir, articulatory acoustic, Christina Taskoff, perceptual measures, Ann Smith, spatial temporal index, Jessica Huber and Elaine Stathopoulos, respiratory kinematics. If you look on the left side, you'll see imaging studies by the Peter Fox group in San Antonio, swallowing studies by Dr. Logeman and her group, changes in vocal cord adduction led by Marshall Smith, changes in aerodynamics with Christopher Dromey and myself, and laryngeal EMG studies with Kristen Baker and Eric Luscheid. So we didn't only examine the primary outcome variable, but we wanted to see the effect of the treatment across the entire speech production mechanism. Next slide. So here we have a video of vocal folds in patients before and after LSVT.
Okay, again. Good, now try a loud one. A nice loud one now. Good, again.
What these data demonstrated to us was that one key physiologic change accompanying successful treatment was an increase in vocal cord closure. We did not see evidence of vocal hyperfunction, nothing that was a negative change in improving glottal closure to support the increase in sound pressure level. Next slide. Another important element is the facial expression in patients with Parkinson's disease. We recognize that patients have masked face, which has a very negative impact on overall communication, as evidenced in this slide. Over time, we have reported a number of studies documenting an improvement in facial expression following LSVT, and I think you saw that in the patient Shirley that you looked at on the video. Next slide. Here are some outcome data done in the research laboratory of Joan Borad using the facial action coding system of Paul Ekman. These data reflect 44 patients with Parkinson's and 11 age-matched controls, and they're looking at one of the measures, which is variability of facial movement. Green is before treatment and red is after. And here we have some outcome data from our newest study that compares high-effort articulation treatment, as you see on the far left, to LSVT, to a normal control group, untreated, and to an untreated group of individuals with Parkinson's disease. And what you can see is this variability of facial movement, specifically following LSVT, significantly increased before and after treatment for the LSVT group, but did not significantly change for any other group. So these are very exciting findings, and they're quite consistent with the previous articles published by Jennifer Spielman and Joan Borad, and give us some support for the idea that after LSVT, patients are increasing in the variability of facial movement, which allows them to be more communicatively effective. Next slide. So we're excited to report that we have completed our third randomized control trial on LSVT. We looked at 84 subjects randomized into 4 groups. 2 groups received intensive treatment, LSVT, or a matched treatment in articulation. 2 groups remained untreated, Parkinson's and non-Parkinson's. The sample size was 20 per group with a statistical power of 0.80. I'll be showing you the data from 3 Parkinson groups here today. Next slide. This is the study progression. As you see on the far left, over 400 individuals were screened to enroll 64 subjects. Pre-treatment assessments were collected from neurology, ENT, neuropsychology, swallow, speech lab data, and based on those outcome data, patients were stratified and minimized into one of 3 treatment groups. The treatment was 1 month in duration, 16 sessions of treatment. In addition, patients had daily homework and carryover all 16 days of the treatment and across the entire month. The post-treatment data were collected. Speech lab assessment was repeated twice in addition to swallowing. And then for 6 months, there was no treatment, and patients returned to the research lab at 6 months for the speech lab assessment. It's important to point out that pre-treatment, there were no statistically significant differences among the treatment groups on any of the outcome variables. Next slide. So here we have data on our primary outcome variable, decibels of sound pressure level at 30 centimeters. On the vertical ordinate is sound pressure level. Across the horizontal ordinate, you see pre, post, and 6-month follow-up. LSVT is plotted in blue, our TIC is plotted in red, and the untreated control group is plotted in green. And you see pre-treatment, all patient groups were the same. Both groups, LSVT and our TIC, had a significant increase in sound pressure level pre to post treatment, but the magnitude of change for LSVT was statistically significantly greater, and only LSVT patients maintained that difference 6-month follow-up. Next slide. You see the same outcome for the CITI, which is a self-rating scale of communication. Pre-treatment, post-treatment, and 6-month follow-up, LSVT in blue, our TIC in red, and untreated in green. And again, you see a significant improvement for both LSVT and our TIC, but only LSVT maintained that improvement at 6-month follow-up. Next slide. We are processing a whole range of outcome variables on this very large randomized controlled data set, but these outcome data are quite consistent with the previous 2 randomized control trials, and now we have 3 randomized control trials supporting the outcomes of LSVT. Outcome data are wonderful, and as clinicians, we should be very proud when our field is generating such data. But also as clinicians, what we really love is when our patients report a major life impact. And these patients report to us things such as, my voice is alive again, I can talk to my grandchildren, I feel like my old self, I am confident I can communicate. So when you have these outcome data and your patients report positive impact of what you're doing, you feel like you're on the right track, and it's a very good outcome. Next slide. It looks like it's a poll question from Dr. Fox.
Indeed. So our next poll that we'd like to ask you, we've been talking a lot about adults, a lot about people with Parkinson's disease, and we're curious, is that a population you're planning to work with, or you're not sure, or where are you going to come in? Or if you're already working, who is it that you work with? So we'll allow a few more moments for the poll here. Some people are still voting. All right, we'll go ahead and close the poll now and share our results. So it looks like 36% are pretty sure you're with adults, 13% pediatrics, 33% some kind of combination, 18% not quite sure. Well, the reason we wanted to ask that, as I turn it back over to Dr. Ramig now, is that LSVT actually has an impact beyond Parkinson's disease. So Dr. Ramig, back to you.
Perfect. And so while the Parkinson data are very strong, having 3 randomized control trials, we've done some phase 1 and phase 2 single subject design, small group studies in a range of patient populations beyond Parkinson's. And they're listed here along with the articles that have been published documenting the outcomes, ranging from adult disorders even to children. So I'm going to give you 2 examples here. The first video is an individual who's had a stroke, and you'll see him pre-post LSVT.
Voice. What do you think about your voice?
Well, my voice sounds pinched, and I get out of breath easily.
Okay. How often do you feel that people have a hard time understanding you?
Every day.
Every day? Have you noticed any changes in
Oh, yes. Oh, yes.
Tell me about
Well, I find that I speak more distinctly, and I find that my intonation is better, and I surely speak louder.
Very good. Has anyone commented it's easier to understand?
Oh, yes. Oh, yes.
Tell me.
So this patient had a very interesting outcome, which is very exciting, and you see on the preceding slide, there are 3 articles that outcome data from individuals with stroke have been summarized. Again, they're small data sets, but they're very encouraging. And now, we'd like to point an example with Down syndrome. She's 5 years old. At the top is the waveform, at the bottom is the spectra, and pre-LSVT, she is saying, I need help.
I need help. I need help.
And again, great. And next slide. And here she is post.
I need help. I need help.
Great. So that's a very exciting outcome with this child, and the work of Dr. Carol Bolick and Dr. Fox in the world of cerebral palsy are also bringing us very exciting data applying LSVT beyond Parkinson's and adult disorder to pediatrics. So we're just whetting your appetite for the potential, and thank you very much. And now I will turn this back to Dr. Fox, who will jump in to some LSVT key concepts.
Thank you, Dr. Ramig. So let's keep cruising on. Now that you've got that wonderful explanation, overview at least of the development and the research data, let's talk about what the treatment is. So first of all, the target of treatment is voice, and in particular, driving amplitude of output. So what we see in people with Parkinson's disease here on your left is that there's a loss of motor energy. So movements for speech are under scale. Patients may not take a big enough breath. They may not close their vocal folds all the way, open their mouth all the way. So what can come out is soft, monotone, underscaled speech. We use that one single cue of loudness to drive greater effort. And with that one cue of loud, we've seen changes respiratory, phonatory, articulatory support, as well as those changes you saw in some of the videos. So the affect, facial expression, etc., all change with that one simple cue. And it's important to recognize, as you saw with those vocal folds, it's healthy vocal loudness. We're never teaching somebody to talk too loud. Rather, we're using our clinical skills, our perceptual ear to shape and model healthy, good quality for patients with Parkinson's disease. The second key concept is the mode of delivery, and the mode of delivery is intensive. So treatment is delivered 4 consecutive days a week for 4 consecutive weeks. Sessions are 1 hour in duration, and they're individual treatment sessions. All 30 days of the month, patients are assigned daily homework practice. All 30 days of the month, people are assigned carryover exercises. And while they're with us in treatment, we're really developing this lifelong habit of continuous practice. So we can achieve those changes like you saw in Shirley, but people need to continue to practice after treatment is over to maintain those positive treatment outcomes. So the intensity is also within treatment sessions. And so people are working hard, from small children in the pediatric populations to our very frail and quite elderly people with Parkinson's disease. They're exercising to the maximum of their capacity so that they're really driving this effort to maximize plasticity. Calibration is the third key concept, and what calibration does is address barriers to generalization. So we could do those motor exercises, but if we only did those motor exercises, changes in the treatment room would disappear on the way to the parking lot. And that's because people with Parkinson's disease have a sensory disorder. They think that their speech that is soft is within normal limits. And when we get them louder, they're going to feel like they're shouting. So we have to teach them what feels too loud to you is actually within normal limits. They have a problem with internal cueing. And so oftentimes we see the physiological substrate for movement is there. That is, if we cue them to get louder, they can get louder, but they're not activating that on their own. So we have to retrain their perception of normal loudness so that by the end of treatment, they're habitually cueing themselves to use greater effort to have a louder voice that people perceive as within normal limits. And then finally, even in early Parkinson's disease, individuals have subtle neuropsychological changes. These are things such as slower thinking, slower learning, problem sustaining attention, problem shifting cognitive set. And when you have that subtle neuropsychological profile, you need a treatment that takes that into consideration. So something that is simple for the patient, 1 cue loud, redundant, repetitive, that is what can really help people learn. So let's take a look at the actual protocol. The treatment session in general is divided into 2 halves. The first half of the session are spent on daily exercises, the second half in the hierarchy. I'm not going to spend a lot of time on this. This is what the training and certification is about, to learn these in detail. But I'll introduce you to the exercises. So one of the exercises is a sustained healthy, good loudness for as long as you can. That builds endurance, it builds repetition, it builds the sort of baseline for the amount of effort and loudness that we then tell patients to use into speech. We do frequency ranges. This helps improve range of motion and laryngeal muscles, which can help impact intonation and really improve the monotone speech of people with Parkinson's disease. Then we have patients come up with 10 functional phrases they say absolutely every day. This could be something like, where are my glasses? Turn down the TV. I love you. You practice those 5 times a day, every day. What this does is allow patients to overlearn things they say every day. So when they're at home in their real world, they say those phrases. It becomes a cue, a hook, a reminder. I'm supposed to use my loud voice. This is the volume. This is the effort I need to use. In the second half of the session, we take that voice that we've rescaled in the first half and we systematically train it into speech. So across the 4 weeks, we build up endurance from words to phrases to sentences, paragraphs, conversation. All of the speech that's practiced is geared towards patients' long-term communication goals, and materials are meaningful, salient to each individual person. We also provide homework practice all 30 days of the week, specific exercises they do every day, non-treatment days twice a day, so that at the end of the 16 sessions, they do their homework after treatment is over. And then finally, carryover exercises really help with this idea that your patient may do everything that you ask them to do in the treatment room, but it feels too loud to them. So they walk out the door and they go back to their soft voice. Carryover exercises require them to walk out the door, use that loud voice in a specific assignment with someone in the real world, and see how people respond. And when patients do that and they see that, oh wow, I just said that, I felt like I was shouting, and nobody responded like I was crazy, or people told me I sounded good, it gives them the confidence that what feels and sounds too loud for them is actually perceived as normal loudness. So ultimately, our goal is we use those exercises, long ah, high ah, low ah, that we saw in that first half of the previous slide, to train up the system, but that is not the target of treatment. The target of treatment is that they then take that improved communication and put it into conversation in their daily life. And that is that whole second half of the treatment session that works on that speech hierarchy. And along with those motor exercises, as we mentioned, we have to address that mismatch in that internal perception of what vocal loudness is and how others perceive it. So they recognize that they are indeed too soft, and that when they speak louder, it's perceived by others as within normal limits. So with that overview of data, of key concepts, of some of the exercises, again, we're just giving a high-level overview. I just want to touch on things because you may be sitting there and going, wow, that's great. That's in research. That may be consistent with all these principles. Can anybody in the real world actually deliver that? And there was a beautiful a commentary written by Beth Fisher that really addressed that head on, and that is interventions that challenge the nervous system can confront real world challenges of clinical practice. So it's important when we have evidence-based practice, when we have neuroscience data, when we understand what really changes, is that we don't just say, well, my clinical practice won't do that because it's status quo, it's always how we've done it. Change clinical practice. And by doing that, you maintain the fidelity of the treatment that's been researched. So we're going to highlight a few ways that you can do that in a feasible way. One is our ability to increase accessibility for patients. So there's all kinds of barriers to intensive treatment. People live too far away. They don't live in a city where they're certified clinicians. It's physically demanding to get to the clinic for those 16 sessions. So two things we developed. One is telemedicine, what we call LSVT LOUD. There are a number of articles published, 5 to 6, that have shown LSVT delivered by a telehealth is as effective as face-to-face. Telehealth would be not unlike the webinar tonight. You'd be at your home or office. I'd be at my home or office. We'd do a video conferencing and deliver the treatment. It's a fabulous way to address those geographic barriers. The other is our LSVT Companion, which was a software system developed by NIH and Michael J. Fox Foundation. And in our research study, half of the sessions were done face-to-face, half of the sessions patients practiced alone. And what you see on the axis here are decibels of sound pressure level across a range of tasks. Pre is purple, post is peach, follow-up is yellow. And across all of these tasks, pre, post, follow-up, when half of the sessions were at home with the companion, outcome data were as good as if all sessions were done face-to-face. So for the right client, this study was published in 2012. Angela Halpern was the first author. It actually won Article of the Year for the American Journal of Speech Language Pathology in 2012. If you're interested in this mode of delivery, read the article, understand how it was used, but it's a beautiful way to increase accessibility. Other things that we're developing are standardized maintenance programs so that once the treatment is over, let's keep patients engaged. That's our Loud for Life program. We also offer to the PD community webinars, expert questions. We have the companion system. We have a DVD of homework exercises. So all ways to keep patients engaged beyond those initial 16 sessions so that they can maintain the improvements in voice and speech and communication. You know, another concern people have is, well, does anybody pay for it? Is it practical? Is it feasible? Is it applicable? And again, these are things we go into detail in our training sessions, but I just want you to walk away from tonight to know that yes, it's imminently reimbursable. We've had success, real world success with thousands of patients. It's practical and feasible. It may require some paradigm shifts on how treatment is typically delivered, but we teach you how to do that. And it's been implemented in many settings: home health, outpatient, nursing facilities, private practice, etc. So what about accessibility for clinicians or students such as yourself? So we have LSVT LOUD training and certification courses. It's not just the training. It's actually a lifelong relationship, just like we want to establish that with our patients. We want to establish that with the people we train. So even after you take the course, online or live, which I'll talk about next, you have access to free webinars for certified clinicians, just like the student webinar you're attending tonight. We have discussion forums. We have clinical experts available. We have a global database so you can facilitate clinician referrals. We have materials for facilitating referrals. So we are here beyond just the 2-day or 12-hour online course to help you be successful with the treatment. And we have over 16,000 LSVT LOUD certified clinicians to date in 69 countries that we've trained over the years. What's exciting now is that the entire training course can be done completely online. So you could be just as you are now at home, perhaps in your pajamas, and relaxed and log on online individually and take the 12-hour course. There's also group learning, there's university learning. We have a range of models, and if you're interested in learning more, please let us know. And here's just a short quote from an online learner. I found it to be an excellent experience. I was initially concerned that it'd be difficult to learn without that live experience, but the video clips, coupled with the organization, comprehensive presentation, were very effective. So the online training is a beautiful way to access knowledge at your fingertips at any time. We also, however, do live 2-day training courses, cover the same content and material, and if you're geographically in an area where we have a course, it can be a beautiful way to be trained as well. What's exciting to know is that after training, again, we are here to help and you can utilize your new skill. Students may use LOUD under the supervision of certified clinicians before graduation. Again, in accordance with federal practice regulations, we always are under those guidelines. You can certainly use it as a CF. It can be a tool to give you a competitive edge in terms of seeking out those CF positions. And once you graduate, let us know and we upgrade your status from a certified student to a certified professional. And it's once you're a professional and even as a CF that we then post your listing on the website. There's renewal every 2 years, but it's easy. It's an online course. It's a 2-hour maximum course, and it's a way to keep you updated on our research advances. We also offer for students grants, and I'll have to say that the grants for speech have passed for this year. The letters of intent were due by February. Some of you may have submitted something, but the research does not need to be about LSVT. It simply needs to be about treatment in a neurological population. We will offer these again next year, and our announcement will come out at ASHA 2016. So if you are thinking about treatment research, a thesis, keep this in mind and apply for one of our research grants. In addition, we offer more public webinars. This one was specifically designed for you, students, but if you're interested in learning more about additional topics of LSVT Loud and LSVT Big, this is a list of our currently scheduled courses and webinars, and there'll be more as the year progresses. And as a certified clinician, or while you're taking the online course, you have access to our office hours. And this is a format not unlike what you're experiencing tonight, but it's open mic. We don't present content. We simply are here as faculty to answer your questions. And so for people who are sometimes hesitant about taking the online course for not having access to faculty, this absolutely addresses that and gives you that exact access to faculty. So in conclusion, before we take on questions, as Daniel Webster said, if my possessions were taken from me with one exception, I would choose to keep the power of communication, for by it I would soon regain all the rest. And what we have as speech-language pathologists, and for those of you who are students who are studying, is a very powerful tool to improve the lives of people with Parkinson's disease and other types of neurological disorders and conditions who have motor speech disorders. And so we're very grateful to be able to have evidence-based approaches such as LSVT to help us achieve those goals. So with that, I will, there we go. I will now open for questions. So as I mentioned when we started, there are two ways to answer questions. You can type them in, or you can raise your hand and ask questions. If we don't get to your question within this live format, and as I said, we'll stay on the line for about 10-15 minutes to answer these questions, you can email those in, or we will follow up and send out a follow-up with the questions we didn't answer to all of the participants. If you do need to leave because we have hit our 1 hour mark, you can close out, and again, that survey will appear, so please answer that. Take 5 minutes to give us feedback. So I will start with the first question. Let's see. Oh, it says a couple people wanted to know about the client in the video. And again, I'm not sure which client. I think that must have been the stroke individual, given the time that the question was asked. So that individual was pre-post stroke. Had a nometaphasia, mild aphasia, had received good treatment for his language disorder, but now the motor speech problem was becoming a challenge. Next question from Megan is, what age should a child with Down syndrome start using LSVT? That question would be, it depends. And so what we train in our workshops is to do stimulability testing and see, can they follow directions? Do they have 1-2 word utterances? And if you see that somebody's stimulable, you do a week of trial treatment and you give it a go. Our youngest child we treated, I believe, was between 2 to 3 years old. A little more challenging. Most of the kids we've treated have been from 5 to, school-age children. But I would give everybody a chance. And if you thought somebody might have the potential for improvement, you would want to do that stimulability testing, and you would want to give them a shot to see if the treatment could be effective. Okay, Dr. Ramick, I'll give this next question to you.
Okay.
For the functional phrases, should they be changed after so many sessions? If so, what might be the reason to expand the list of functional phrases for a patient?
Excellent question. And the answer is no. You want to keep those same 10 functional phrases throughout the entire month. And the goal of the functional phrases is they allow the patient to generalize the louder voice into their real world. And if you change them, the likelihood is that generalization won't be as likely to occur. So when I would start, I would say to my patient, think of, 10 things you say every day. Start in the morning, think of the afternoon, think of the evening, and the second day they come back in, we may adjust them a little bit because you want them to be things like, honey, did you turn on the coffee? Did we get the newspaper? Did the dog go out? If you have little kids, did you brush your teeth? Things that you really absolutely positively say every single day so that improved loudness is not only in the treatment room but invades real life. And those things, when they're overlearned, will pop out of the mouth of the patient in their real world, and people will react to them, and they will notice, wow, when I use my increased loudness, it really helps people hear and understand me in my normal everyday living. So for the functional phrases, they say the same throughout the whole treatment. In the second half of the session, when you get into the hierarchy, everything changes. But the functional phrases stay the same throughout the entire month.
Okay, so next question is, let's see. So you primarily use the cue loud. What kind of cue impact do cues like strong or support had on patients? Does it cause strain or any harshness? So yes, the word loud for Parkinson disease is the key, and that is because their primary symptom is they're too soft. So we use loud as a cue to drive that effort and increase that amplitude output, which we know is so important. Patients will immediately say, I feel like I'm talking too loud. As I mentioned before, we're not training them to talk too loud. Loud is a cue to drive that effort. Now, if someone is really resistant to that, and you can use the word strong voice or power voice, and you're modeling loudness and you're getting the loudness you want, that's not fatal. Sometimes with children we use that because they're not supposed to talk loud, quote unquote, in school. But don't nerd out on it. Loud is a cue that works for 99% of the people, and it really drives healthy vocal loudness. And that's what you want to reiterate with the patient. I'm not teaching you to talk too loud. You had disordered loudness. So I'm teaching you healthy, normal loudness. Next slide, Dr. Ramick, we'll give this one to you. If the patient feels as though they did not improve enough throughout the 4 weeks of treatment, is the patient allowed to participate in another 4-week LSVT treatment to further improve, or are they limited to just maintenance programs?
That's a very, very nice question, and I'll tell you the answer that we've discovered over the years of our research. If the patient has idiopathic Parkinson disease, stage 1 through, let's say, 3.5, and the clinician is in there pushing the patient every single day, recognizing that they have 1 month to get that patient to improve functional communication, we've never run into a patient who's needed more treatment after 1 month. You certainly can follow up at 3 months or 6 months and see how they're doing, and that's a fine thing. But if they have idiopathic Parkinson's and the clinician is really in there doing the treatment as they are trained, patients will have a really fine outcome. Now, having said that, there are other types of Parkinson's, such as multisystem atrophy, Shy-Drager syndrome, progressive supranuclear palsy, Parkinson patients who've had deep brain stimulation. They may be an entirely different situation. And in that case, you'd still jump in and you'd still do the treatment with gusto for a month. But in those cases, you may actually need to continue the treatment a bit longer or give them a break for a few weeks, and you may need to cycle back in. We actually have never had a patient that has needed the 4 weeks and then within a couple months needed the 4 weeks again. That would be a very rare outcome. But it is absolutely true when you're dealing with some of those Parkinsonisms because of the cognitive challenges, the progression of the disease, etc., and patients who've had deep brain stimulation, they may absolutely need additional treatment. And that's your clinical decision when those patients are in your hands. But if you're dealing with a classic idiopathic Parkinson patient, stage 1 through, let's say, stage 3.5, 1 month is great.
Excellent, thank you. We'll take one comment and then one last question. The comment one of the students wrote in, which was a big thanks to Dr. Odom, that many of the students here were invited by her. So we'd like to reiterate that thank you for sharing this information with your students and for all of you attending here tonight. So the last question that we'll take, because I know it's getting late, and again, if your question did not get answered, we can follow up. And that question is this: is LSVT LOUD an option for individuals that are currently using an AAC device? Can they continue to use an AAC device? And that's an important question. Most likely that's someone with more advanced Parkinson disease and certainly more severe dysarthria. And I would say give them a chance. I would bring them in, I would do stimulability testing, and I would see, can we get some vocalization from this person even though they're on the AAC device? If yes, I would proceed with trial treatment. Those functional phrases that we mentioned and Dr. Ramig just talked about in more detail, of the utmost importance, because even though they may have to rely on the alternative device, if you can give that person 10, 15 phrases or more that they can orally communicate, it can be a huge value to quality of life for those individuals. So you have to take that on a case-by-case basis, but don't discount them as a potential client just because they have AAC. Bring them in, test it out, and then if you see something that you see as stimulable, do trial treatment. Okay, with that, we are going to close the show for the evening. Again, on behalf of Dr. Ramig and myself, we thank you so much for attending tonight. We're thrilled to have students who want to learn more. Send us additional questions, visit the website, let us know what else we can offer to be helpful to you. Have a good evening and good luck with the rest of your semester.
Bye.